Khalid Tamam, a good friend and the CTO expert, is based in Jeddah and Cairo now, in two centers, but in both places he's doing CTOs, and he's having a very interesting and very important meeting, IMC Congress, that will be taking place this year virtually, I think, in January.
In April, no, in April it will be hybrid.
Oh, sorry.
Hybrid, yes.
All right. Khalid, thank you very much. So, Chris, the floor is yours. It was supposed to be a live transmission, but for technical reasons and non-availability of crew, we have to switch to plan B, which is to record the case, and I will let Chris telling us about the whole thing. Thank you, Chris.
Excellent. Thank you, and good afternoon from South Africa. And it was interesting to listen to the previous talks, and actually a lot of what was mentioned in the previous talks are going to be in the case presentation that I did. I'm not sure. I'm just going to let the case run and speak, but if there's any questions, I'm sure you can interrupt me. Can everyone see what I've shared?
Yes, yes, very well.
Excellent. So it's a reattempt to the right coronary artery.
Here we are injecting into the right coronary artery, and you can see that it is totally occluded in the mid segment. The cap appears to be quite a blunt cap, and that is pointed to by the green arrow. The blue arrow is pointing towards a side branch which is coming off at the cap. If you look closely, there might be a small little rat's tail going down the vessel, but remember, this is a reattempt, and I suspect that this is actually from the previous attempt, and it is going into the false lumen that the previous operator had entered. Here we're doing a dual injection, and this is a must when you're doing any CTO, as it's going to help you visualize the distal vessel, and it'll also help you visualize the distal cap, and it'll also help you assess the length of the lesion and the collaterals. So we can see here, and it's highlighted in red, that there's retrograde filling of the right coronary artery, the PDA and the PLA. You can see that it is a very diseased vessel, and that even though they are both filling, it is difficult to actually see any flow past the bifurcation, and there's even some disease at the bifurcation. You can see that they are filled by good collaterals, and these are septal collaterals from the first septal perforator, which is a large vessel. It bifurcates into various branches, and there are several branches which then connect to the PDA. The green arrow is pointing towards the previous stent that was placed, and you can see that the stent is in the CTO segment. So after we do our dual injection, we can assess and plan our strategy. We can see that this is a very long CTO segment. If we look at the proximal cap, as we said, there's a blunt ambiguous cap, and we can see that distally we need to save the bifurcation, which is diffusely diseased, and we have good collaterals that we can go retrograde. So ideally, this is primarily a retrograde case, where we will go retrograde and then try and join the two, doing the reverse cart. The reverse cart we will try and do where we think we either both your antegrade and retrograde Y are either in the true lumen or subinterval space. And ideally here we have a stent, so if we can get both antegrade and retrograde in the stent, we know that we're in the same space, and we can then do the reverse cart. So to engage the right coronary artery, we used an AL1, which is sitting quite nicely, and it's going to give us enough backup. And on the left-hand side, we've got a EBU4 guide catheter, and that's what we're going to use to go retrograde. Let's do our dual injection. So,
Chris, may I ask you a question at this point?
Yes.
Yes. My question to you is the definition or the decision to go retrograde. So you define based on the anatomy would you give it a try systematically to an integrated approach? Because actually it is true that you don't have a tapered stump, but even in those cases, sometimes when you put the wire, you're sometimes surprised that it goes through. And is that your strategy or that's your experience?
I agree with you, because remember, even if you have to go retrograde, you're aiming to do a reverse cart. So you're going to need to do some antegrade work as well. So there's no harm in actually starting off, if you want antegrade, and like you say, sometimes the wire slips through. In this case, I decided to go retrograde from the beginning for a number of reasons. Firstly, because it was reattempted quite recently, and the person that attempted it had gone subintimally, and I think there was still a dissection there. So I was worried that we wouldn't actually join. And also that distal vessel was so diseased, to try and save the bifurcation, I thought it would be safer to go retrograde. But I agree with you, the majority of my cases, I'm going to start doing some antegrade work. If we're lucky and the wire slips through, it's done. But if not, you've already done some of the work for the reverse cart.
Yeah, but I agree with you, Chris, to start right away retrograde, because it will need time. So I think to just keep your effort for starting retrograde, it's better to start antegrade. Because usually when we start antegrade, we say we'll give just 5-minute trials, but end up by two hours. So
exactly, yeah. You sometimes get absorbed into it and you think you're close.
Yeah. So I agree with you that this is the case is we have to save the radiation, save the contrast. We go and put retrograde, even we put a retrograde marker and then start antegrade.
Correct.
So I'm agree with you.
No,
okay, go ahead.
That's the right. So, okay, so first let's go to the, let's do an LO cranial. Okay, all right, so it's got to be off mag, and you've got to make sure that you've got, just go a little bit more to the, no, 1 mag more is fine. Yeah, just move the table a bit so that we get the right coronary artery fully in, right. Okay, all right, so Isabel, you're going to go first, and then Riaz will follow. Wait, okay, go. And Riaz. All right, let's do an AP cranial.
So I'm just going to pause there and I'm going to move forward a bit. But remember, you have to do a retrograde injection. You've got to do a dual injection if you're going to go retrograde or for any CTO. And remember, you've got to do it in different views so that you can get an idea of what you're dealing with. So I'm not going to bore you with sort of here's the other view.
At the bifurcation, and that's why if we need to save the bifurcation, 10 to 1, we're going to need to go retrograde so that we go through the bifurcation and save the bifurcation. Yeah, this one, yeah, and then you can go either one of them, but I think that one, yeah. Okay. So the microcatheter that we're going to use now is the new, let me wave and just bring the box so we can show them the box shot. It's the first time we're using it. All right. So if you have a look and see, it's the Asahi Corsair Pro XS, and it's the thinnest microcatheter currently on the market. The other good thing about it is, whereas before the Caravelle, which was also quite thin, but it had a tip that sometimes used to disconnect if you torqued it and it would grip, this one's got a shorter tip, and you can actually get a lot of torque out of this, and the tip won't disconnect. So it's essentially a very, very thin Corsair. Give me the sign black. So to get into the LAD, you can use any wire, but to try and save on wires, what I do is my workhorse wire anyway is usually the sign black, and I'll show you now. Yeah. So what I normally do is put a very short distal tip, which is only about 1 or 2 millimeters, and then I put a secondary bend which will give me some kind of control to get into the LAD and to get into the septal. And remember, once you're in the septal and you've actually in the microchannels, what happens is the microchannels will straighten the secondary bend, and you're going to be left with your primary bend, which is only about 1 or 2 millimeters, to then do the septal surfing and try and cross the septals into the right coronary artery. Inject a little bit, but I think that's where we have to be. Nope, totally wrong. That's where we have to be. Okay. Once you get into the septal, you want to advance your microcatheter that's at the septal, but you don't want to advance it too far down, because what happens is it'll then give too much support and your wire then becomes like a needle and you're going to perforate. So you just put it in and support. This is what we call septal surfing, where we are just going to go down and see if we can't find a communication.
Just going to pause there. The reason why I've left in some of the septal surfing is for the younger operators or people that want to get into CTOs. I think the most important thing is if you can just look at my hands in the different views and see that there's very little pushing, or actually no pushing of the wire. It's all got to do with spinning and rotating the wire. And what you do is you sort of keep spinning, rotating the wire with very little forward pressure to see if it's going to take any of the microchannels. If you feel resistance, and it's got a lot to do with tactile feedback as well, stop, pull back, and try and find a different microchannel. So the mistake that a lot of the younger operators are doing is it's not an open vessel like we do before, where you sort of point the wire and just push as hard as you can to try and get it down. It's all got to do with rotation. So I'm just going to let it run for 30 minutes or 30 seconds to a minute, but please have a look and see the hands, and everyone rotates it in a different way. I hold it from the top down, others hold it in their palm of their hands, but as long as it is it's rotation of the wire and very little pushing.
Just inject a bit there, Isabella, we're in the right. So many. That's a different, that was a different angle. Okay, this probably needs to take a different one from the top. Okay, so the good thing is with this now, you can just give it the little primary bend. And a very small little secondary bend. So essentially, I think he's got it, yeah. Okay. That one doesn't seem to go. That's a dead end. Let's see this one. That's going nicely.
That's different.
Yeah, it was just decide to go in, but it doesn't. That's going wrong direction. Contrast.
try and
I
see
normally will give it
for her.
5, 6, 7 minutes of septal surfing, because remember, you know that one of those will join, and you're hoping by just going back and forth and trying to take different septal perforators, you'll be able to join. If you're not able to join, then what you do is what we call a tip injection, and that's what I'm going to show you now. And that is where you actually inject through the microcatheter to try and then target which collaterals join, and then you can get into that collateral and then try and cross that way.
Chris, do you need to change the wire sometimes? You're using the same black, right?
So actually over there you saw that I did change the wire. So what happened is with that first wire, as I went down, it was quite difficult. It looked like it was going in the right direction. And with all the sort of torquing and spinning, it's folded on itself and knuckled. So you know that when the wire, loses its integrity, you don't want to persevere with the damaged wire. So then you can change. So I changed to the Sign Black, which is my favorite wire. But sometimes you have to go with something that's a little bit more tapered, like an XTR, or sometimes even with the Fielder FC. So it all depends. Everyone's going to have their favorite or the wire that they prefer, but that's sort of the choice, my choice as I go along.
Going to do what we call a tip injection to try and see or hone in on 1 or 2 branches that do join. So you use neat contrast, and then you have to suck back.
Excuse me, Chris. Can you focus on the angios?
Otherwise, you don't get blood back.
Is it possible to do it?
Unfortunately, the way that they've sort of spliced it and put it together, I can only show all of them together, but I'll point. So essentially, you need to suck back and make sure that you get blood back.
If you inject with force, you're going to rupture the vessel. Okay. I don't see it filling. Yeah, give me the. Give me a flush. Yeah, there it is. It fills. Right. So sometimes the contrast is very thick and it doesn't show.
It's one of those
but
branches there.
Yeah. So just play it frame by frame. Freeze.
This is the
So
top
it's
branch.
top branch coming
top
down
branch,
this way. Yeah. Okay.
So you gotta go there.
This one here, yeah. Okay. So it looks as if there's one branch there.
Yeah.
Okay. So let's see. Give me the shaping needle. Yeah, so it's has got that funny upward bend. Let's hope we can take it. Come back a little bit. Inject a bit there. Yep, that's the one.
That's gotta go that way.
Yeah.
You can see that we needed to target slightly higher up and one coming to the left.
Okay, that's different, Chris.
Yeah.
It's different. Yeah. It's the right channel. Let's go through that stent, yeah. It's on the
And
right.
you can see, as I'm going to say now, is that it's taking different branches, so you know you're in the right area, but we'll do an injection to be on the safe side.
Let's do a run. Wait.
Let's do a run there. Yep, we're in. Okay, so we managed to join, we're in. What worries me a little bit is that curve there, but I think we should be fine. We'll straighten it and we shouldn't have much problem. Okay, so go through to the AP. Yeah, but we're going to do that now. So let's get our microcatheter down. Let's go to the AP cranial.
So you're at the bifurcation where you're sitting at now.
Yeah, so that's the bifurcation's going up. So okay. Okay, so if you see the way that we're going to advance the microcatheter, especially the corset, remember it's got that corkscrew effect. It will grip, it will dilate, and it's going to advance. So with your one hand, you're going to be rotating, and you can rotate mainly clockwise. And if you remember, every now and then, you just give it a few anti-clockwise rotations. And then with your other hand, which is sitting sort of at the hub, you're gently advancing and pushing forward, and you're going to see how it advances on. Yeah, so you can see. Okay, so actually, this new Corsair Pro XS actually going very nicely. I'm able to torque it, and it's actually following the vessel. It does worry me a bit, the angle at the bottom. If I do push too hard, where is that going to? The concern was this angle over here at the bottom, because you can see it's quite an acute angle, and the concern is sometimes if there's a very hard lesion that you're trying to push, you're advancing your microcatheter, you're hitting a brick wall here, and then a lot of the pressure starts building up over here, and it can sometimes rupture the septal perforator. So you really need to be careful over there. But this was the first or second time that I was using this Corsair Pro XS, and it actually behaved really, really well. Where am I going to give most of the force? But at the moment, I'm happy. Just want to come back and get into the vessel. Right, let's just do a run there, Isabel. Okay. Right. What I haven't shown is that this was such a diffusely diseased vessel that I tried to do a tip injection and you could hardly see anything. And that's why we're doing an injection in the LAD. So normally what you do is once you get it down, you've crossed, and you're in the small vessel, as we saw in one of the presentations, you remove your wire and you do a tip injection, and that will then show you exactly if there's a little microchannel, where the bifurcation is, etc. Give me the Gladius, Waven. I'm not sure if you have the Gladius available. It was the first time I was using the Gladius. And as you know, the Gladius is one of the new wires from Asahi, which is about a 3-gram tip. But the nice thing about it, they've created an area of weakness, and it allows you to knuckle. So it's almost a specially made knuckle wire, and it actually gives you a nice controlled knuckle. Try that. Yeah, so this is the Gladius wire that I'm putting in. And the nice thing about the Gladius wire is that they've now created a weakness further back, and it's an ideal wire to knuckle. So if we can get into the right coronary artery, we...
The name escapes me.
Just do a run. Yeah, go for it. Okay, so we just passed the bifurcation. Can you see there? Yeah, but can you see the bifurcation is there?
Yeah,
so we passed the bifurcation. So if I can get the Pro, the microcatheter, a little bit further in.
Chris, there is no way to show the angio because we only see your hand.
The
angio will come just now. I'm not sure why they didn't put it on, but you're going to see now the angio in 30 seconds.
And give me enough backup. If not, that'll be the next plan. So we need to get something to redirect into the stent. So give us see that it's already got a little pre-shaped curve of about 1 millimeter or 2, and it's got a 1-to-1 torque. So we'll be able to direct it, get into the stent, and then we'll.
So with the Gladius, we kept going around the stent. So what I've done now is I'm taking a Gaia second, which is more directional and it's got more strength, to try and see if we can't then go through the cap and into the stent.
Go back to the Gladius to knuckle up.
So because we don't see the angio clearly, the stent until the cracks, the RCA stent is still until the cracks, the CTO segment inside the stent is before the cracks or the middle thing?
No, so the stent is about a half a centimeter to a centimeter before the bifurcation. So it's in the middle of the CTO segment. You'll see now, sorry, I'm not sure why they didn't put the video, but I mean the angio, but you'll see the angio in a minute.
Because there seems to go to the.
I think you can run it until you see the video and then
there we are.
You explain for us. Yes, coming. Yeah.
So the guy's second, I think I'm through this.
So the crux is over here, and the stent starts over here. So there's about a half a centimeter before the bifurcation. So it's a stent, half a centimeter, and then the bifurcation.
So let me try and get the microcatheter.
So we crossed with the Gaia second, and it was in the right place.
Yeah. So we're going to do that now. I just need to get, and I really like this microcatheter because even though it's nice and thin, you can see that it is very torqueable and very pushable, and it's actually progressing quite nicely through the lesion.
Your catheter is giving good support as well.
Yeah.
It's not building your guide.
Let's get the Gladius back because I want to knuckle. Because that will create a much bigger channel. Okay, and then I need a 135 Corsair. And an XTA so that we can go Antegrade and try and do the reverse clot in the middle.
Microcatheter is on the stent, eh?
Yeah.
Yep.
Why is it going out? Why is it going out? That's what doesn't make sense. Okay.
So you can see that the microcatheter is what it appears to be in the stent, but when we take out the Gladius and it knuckles, and you can see that it actually forms a very small little knuckle, but it's outside of the vessel. You can see that it's not following the stent. The stent that Dr. Dawood must have put in was undersized. Actually,
come to the
thought that our guy had gone through the stent, but the guy actually was outside the stent. So what we need to do now is redirect.
weird. It seems to be going out of the
Dr.
stent.
Chris, you don't have any bigger angio, because also the visualization for us, it's so difficult. We need to see it much better. You don't have it, huh?
It's on a different thing. I'll try and show you just now. Let me first just go through this, and then I'll show you now with a slightly bigger one, hopefully.
About the stent on this one. You see, we're sitting on top of the stent there. You've always got to be careful that your catheter does not get sucked in. So you pull that back.
Yeah, I think this is very, very important step what Dr. Chris doing now. Just to be always care about donor artery, because usually we forget this kind, and the donor artery is stuck when you try to pull the microcatheter. Your guiding is dissecting the left main, and patient collapse, and you don't know why he collapsing.
Yeah, so it's important. I agree with you there. You as the operator should be aware of it, but sometimes if you forget, whoever you're working with, you should make them very conscious and aware, because sometimes you're so busy and absorbed where your wire is and where the tip of your microcatheter is that you're not looking. So I've got, my assistant and especially my technologist, as soon as he sees that there's any damping of pressures, he's going to shout at me and say, listen, pressures are damped, what's happening? You really need to be aware of that, because that's where you can ruin a case.
You want the Antegrade injection?
Can you move the video a little bit? Maybe we see the angio, because
Too far back. Okay, go back into the. Okay, give me the sign black again. Let me just try and get again into the stent, and then. So when I pulled back, it came back a bit too much, but I didn't want to cause any damage, so it's safer.
That's what we got last time.
Yeah. So I got to there. Then we're going
Took the tire from
Yeah, so let me first
facing up the microcatheter.
So, Dr. Chris, let me ask you here, while you are trying to go through the stent with Gaia. Do you think it's better to have a supporting guideliner or guidezilla before to start, to get better support to the microcatheter, to be more control before you start?
Well, normally in the wire or the catheter that I'm going to go retrograde with, I'll always go with a catheter that gives me enough backup. So in this case, it's an EBU or an extra backup guide catheter. Most of the times I'll go with 7 French, which gives me extra backup. And yes, if I'm struggling, I could always put in a guideliner. But remember, you're going to be putting in a guideliner or guide extension into the left main, and you're going to have a much higher probability of ischemia. So what I find is by just using a catheter that gives you good support, 7 French, you're actually having more than enough support. And you'll see that we had more than enough support here. It was just a matter of getting into the stent and being able to do the reverse cart.
Yeah, that's what I'm doing very gently, because I don't want it to jump too far back.
Yeah, that's the direction. It's going that.
So if you have a look at the angiogram here, I know it's small, sorry about that. You can actually see that the sign black, this is a sign black. I wanted to get past the bifurcation and then change again to a Gaia, but you'll see that actually the Sign black hooks onto the stent and actually knuckles into the stent. And then I knew that if a knuckle goes in, I must be in the true lumen. Or not true lumen, but I must be in the lumen of the stent. So you'll be able to see here as it knuckles.
Your guide cut is a bit shallow. It needs to be a little bit, yeah. Okay, that's better. Knuckle boy.
You can see the knuckle. You'll see it at the bottom here, and it advances inside the stent.
Okay.
I'm just going to look in 2 or 3 different views to make sure that I truly am in the stent.
It seems as if it's through on this one. Come to the AP cranial and then RAO. Let's just make sure that we... Okay, so definitely there's stent on top and stent at the bottom.
Whether you went out in that, but no, it's
Yeah,
knuckle, so you
I don't think so, yeah.
it's knuckle.
I mean, this one looks in, can you see there?
Yes.
Okay, that looks good. Okay, so go back to the LO cranial. Okay, so...
Chris, may I ask a question regarding the time, please? How much time do you have for?
I can speed it up a bit. How much time do we need? How much time do we have? Let me speed it up a little bit and show you the important
Yes,
part.
well, maybe you have 12 minutes. 12 minutes.
Yeah. So, yeah, perfect.
Branch.
So essentially, then
PCI.
we went antegrade. That's putting a Corsair microcatheter antegrade lead with an XTA.
Oh, that's a little side branch that was taken before, and now we know that we have to redirect down here, and that's the nice thing. So that little pathway that
So you can
was
see
there
that
is actually a pathway
we managed to go in the right direction.
created
On the Antegrade.
by the previous. That's a hard cap there.
Major problem was even though this was a AL1 and we've got the microcatheter, the wire down, we just couldn't go through the cap. So again, that was the previous talk that was given. How do we increase our support? Yes, we could upgrade to a 7 French, but the other way that you can do it is put in a guide extension.
And balloon to trap it. So if you have a trapped balloon,
this is very similar to that surfing the wire, the microcatheter out. So we
or trap a balloon, you can use that.
Surf the microcatheter out. Put in a guide extension, so you can see your guide extension is at the bottom. And through that, we went with the 1.5 balloon, and we managed to track the lesion.
iVascular's brought the 1.5 central
Chris,
marker
are you
balloon.
using femoral approach here?
Sorry?
Are you using femoral approach? Is that your routine for such cases?
Yes.
For both?
What do you mean for both?
For both arteries, for the left main and the for the left. I mean for both dual injection are made through femoral approach.
Yes. So I cut it out because it was too long. So normally I will either go bifemoral, and in this patient here, we had used the radial approach before, and the pulse was a bit weak. Otherwise, I will do a femoral and a radial. So it'll be a femoral there and a radial close to you. So it'll be a 7 French through the femoral and 6 French through the radial. Otherwise, bifemoral.
You need to try and do the reverse cart.
Yeah, this is important. I think this was
subbing in the middle in your subintimal space. Marker balloons. Essentially, you need to try and do the reverse cart where either, but so if you've got your lumen in the middle and your subintimal space, they either got to be in the true lumen, but in plaque, or they're both got to be subintimally. If the one's inside the lumen and the one's subintimal, it's very unlikely that you're going to join them. What we managed to do now is I've managed to push going to do advanced in 16.
This is how you advance, as we saw before, the guard extension
As the
over a
balloon
balloon.
comes
So you
down, you
inflate the
can
balloon.
advance
As the balloon is coming down, you advance your guard
guide line,
extension.
so it's all the way in.
And the good thing here now is we know that we've got our antegrade and our retrograde wire within the stent, so we know we're in the same space, so we can actually do the reverse cart or join them inside the stent where we know that we're in the right
Pretty
space.
fine now. So it's got
So your guard extension is over there. There's your microcatheter, and you can see that your retrograde wire is now getting into the guard extension and into your antegrade catheter.
Can we get the RG3?
Yeah, we should be able to. So for resistance,
what we also did
trap.
Is we trapped the wire with the balloon up
So what we can do is
in the catheter,
see if this goes easily.
and that way we were able to advance our microcatheter much quicker, as you're going to see now.
Take the balloon forward that we've got. You can see there. Right, now trap it. Go up with your balloon.
We're going up with the balloon over here, trapping this wire, and that way we can pull and push, and we can get our microcatheter
push and
to
pull.
the guide extension. You can see how easily
Our catheter,
it's advancing.
microcatheter goes nicely into. Okay, it will go from this groin.
This is externalizing the wire, and you can
Just
get the
come out.
wires out the other side.
What we need to do is we need to now pull back
The guideline.
the Corsair Pro that's going retrogradely.
Again, have a look and see how
Remember,
disengaging
as we
my
pull back, it's going to
catheter,
suck
so that
the
we
left
don't cause
catheter.
any left main
So we'll show you on
protection.
the screen, but you disengage the catheter and you haven't caused any damage to the. All right, so I'm pulling back on stent and
You'll just go through that. So we did intravascular ultrasound and it was diffusely disease.
Let's just do a run.
We did a very gentle antegrade injection while we were inside the stent. So, and you can see it's a very diffusely diseased vessel. So we converted it to an antegrade.
So with Suzuki being a dual lumen catheter.
Using a dual lumen catheter. So we put in a Suzuki at the bifurcation. And as you know, Suzuki has got a distal exit and an exit about 0.5 centimeter or so back. And we were able to then very easily get a wire up into the PLA.
Exit. Okay.
And if you have a look here, it goes quite quickly. But the wires, there's the tip of the Suzuki. And we very easily found the PLA. There's the wire going into the PLA.
Just go to that. A PTCI come down.
Angioplasty
in both the branches. And now we're going to do a kiss. So let me just get the two markers.
2 by 20 balloons.
I just don't want to.
And then we entered. I'm just going to go towards the end.
But 20 non-compliant.
Is that stent overlap?
So we stented from here because it was so diffusely diseased till there, and stented with another 2 stents going back. The IVUS showed that the stent that was placed before was only about a 2.75 to a 3 millimeter stent, but the vessel was actually 4. So we went with a 4 non-compliant balloon to high pressures. That's the final stent going in.
Okay, give us a little bit of nitrates. Just pulling back the catheter, the PDA.
Ah, come on.
Yeah, I'll do. Well, from nothing, I think there's something there now.
And that's your final result. So you can see that there is the PLA at the top there. It's a diffusely diseased vessel, but it was started to grow with nitrates. This was done about 2-3 weeks ago. We've seen the patient for a follow-up, and he's actually doing extremely well.
Okay, it's a very nice case. Congratulations for the excellent result. We hope we wish the angio was much clearer than this one to enjoy more your case, because the case is, I think it's fantastic. You did a great job. You show everything in the case, but we need to see it by nice angiographic picture to follow up your steps.
Yeah,
but I think some technicality. Some technicality was for adding. I know it's the last minute, so it's. But let me ask you a question, because we don't follow you about the reverse card. Where is the part you did the reverse card in this case, or you went to intima to intima?
So in this case, we were lucky in that both the antegrade and retrograde wire went inside the stent. So we know that
kissing wire techniques.
Sorry.
You make it kissing wire techniques, yes?
Yes, so essentially what we knew that inside the stent we're in the same space, so we brought the guide extension into the stent, and then we were able to get into the guide extension. So as I mentioned there, you can only really connect if both wires are either intraluminal or both in the subintimal space. So the other option would have been is that if antegradely we got subintimally, then we would have gone a little bit further than the stent, knuckled, and then we would have known that in that space we would have both been in the subintimal space. We would have brought an antegrade balloon and done the reverse cart there. But I think the advantage that we had here, once I knew that we had gone into the stent, I knew that both wires were in the same space.
And both the retrograde wire was a gladius, and then Gaia second, and then you go back again with gladius.
Well, I was going to go back to the gladius, but I was lucky enough that actually the sign black knuckled and went into the stent. So then I left the sign black. But the plan was to go back to the gladius and knuckle with the gladius because it's specifically made for knuckling.
Okay, so this is excellent. So I think by audience, if they would like just to follow up what you did, it was lucky to have the post knuckles or first knuckles. Second one was a conventional antegrade approach with which wire you have been starting. I think you start with a Felder XTR antegrade one.
Antegrade, I went with the XTA. XTA, and I managed to get down, but I couldn't cross with the Corsair as much as I pushed and as much backup I had. So I took out the Corsair, went with the 1.5 central marker balloon. I managed to sort of crack the cap, then went with a 2.5 balloon and sucked the guide extension further down. So
I think Dr. Habib, if you go back to the case, you will start at the antegrade and you finish by antegrade, yes? So you manage at the end.
I have to say that we've been doing CTO for many years, but we usually master the antegrade, but we don't do the retrograde so far. That's why we would like to learn from you and from Chris how to do it.
No, yeah, but I think Chris, if you don't start by retrograde, the case will take 6-7 hours or 5 hours at least.
I think it would have taken longer. And if you have a look and see how much I struggled to actually get into that bifurcation and try and go in the right direction, I think it was a very diffusely diseased. And even if I did manage antegradely, I think I would have most probably broken into the PDA, but further down past the bifurcation. So even though it wasn't a huge PLA, exactly. I think in this patient, it was important to try and save that PLA. And the only way you would have really 100% saved it is with a retrograde approach.
Yeah, I think it's perfect.
What was the duration of the procedure?
It took just under 2 hours. Radiation was, I'm trying to think now, but it was something like 2 gray or something. And contrast was only about 200 or 220 mils. FR was normal.
It always gives the operator confidence that he is going in the correct way, because your antegrade wires is already in true lumen, so you know where you are going. Especially if you have an instant occlusion, very long occlusion has been tried before, always dissected. So retrograde secured your success rate, it became high. So you always know where you go. So I think it's a great case. Hopefully next time we can see good angio, because we could
I'll
not
try and
see
re-edit it and I can
it.
send it to you. You can put it on your website. But yeah, I'll try and get them.
But please, we can't see it by. So any question from Ziad?
No, I think this was very happy and very good result. I think if you were Antegrade, maybe you will be on one dissection after the stent and you will use all the right coronary artery. So I think it was a very good option and very good way to deal with a retrograde approach. I think this case could not be dealt only with anterograde approach.
I agree.
All right. Okay. Thank you, Chris. Once again, that was
thank you.
An excellent case. You have taught us many things, and I would like to thank also all the panelists, Ziad, Khalid, Qais, and we have to break now for a few minutes before resuming at 5 p.m. That's in about 12 minutes for an excellent session on left main. So join us later on. Thank you very much.
Thank you all.
Thank you
very much.